If you've been told you need a dental implant, the real question isn't where to schedule it. It is whether you actually need one, what's going to be put into your jaw, and whether the practitioner planning it has the experience and the honesty to walk you through what could go wrong. Did you know you almost never actually need an implant on the timeline you've been given? This is one of the conversations I have most often in my practice with patients who have just come from a consult and walked out feeling pressured. Today, I want to walk you through the 4 questions I would have you ask any dentist before you let an implant be planned for your mouth. By the end of this video, you'll know what each question reveals, what an honest answer sounds like, what a red flag answer sounds like, and exactly what to do if you hear the wrong one. I'm Dr. Helen Bennett. 25 years in practice, the last 15 as a biomimetic and holistic dentist, which means I focus on saving teeth in ways that respect the rest of the body, not on replacing them whenever it's profitable. Before we get into this, do me a small favor. Drop your city or state in the comments. I love seeing where you're watching from. And one important thing, everything I share is educational. It's not a substitute for in-person dental care. Use it to walk into your dentist's office better prepared, especially before a procedure as final as the one we're discussing. Here's what's at stake when an implant is planned in haste. Sit with this for a moment. A dental implant is, by design, a permanent procedure. A titanium or ceramic post is placed into your jawbone, where it's intended to stay for the rest of your life. Around it, a crown is built. The procedure costs in the range of $3,000 to $6,000 per implant in most parts of this country, sometimes much more. The healing window stretches over months, and while a well-planned implant in the right patient is one of the most beautiful pieces of modern dentistry, an implant placed in the wrong tooth, in the wrong bone, by the wrong hands is the start of a long, expensive, frustrating story that some patients spend the rest of their lives trying to undo. The systemic conversation matters here too. The materials that go into your jaw will live there for decades. The bone grafts that may be used come from various sources, and patients deserve to know which. The healing depends on factors no one will explain unless you ask. Your bone density, your gum biotype, your medications, your hormone status, your overall inflammation. None of this is exotic. All of it is routinely glossed over in a 30-minute implant consult. I don't tell you this to scare you. I tell you because no one else will. And about halfway through, I'm going to share the question that, in my practice, has saved more teeth from being extracted unnecessarily than any other. And most patients have never heard it. Stay with me. Let me back up and lay out the 4 questions, in order, exactly as I would have you ask them. Question 1. Do I actually need this implant, and have we exhausted every reasonable option to save the natural tooth first? This is the question that matters most, and it is one of my biggest pet peeves about my own profession. Reflex extraction of teeth that, with conservative biomimetic technique, could have been saved for another 15 or 20 years. The standard line in many offices is, this tooth has too much decay, or it's broken too badly, or the root canal failed. Let's just take it out and put in an implant. That sometimes is the right answer, but sometimes, and in my experience, more often than the dental industry admits, the tooth could have been restored. A deep crown lengthening, a careful biomimetic buildup, a retreatment of the root canal by an experienced endodontist, ozone disinfection of a borderline infection. Each of those, in the right hands, can extend the life of a natural tooth that was about to be extracted. A good honest answer to this question sounds like yes. In your specific case, the tooth has a vertical root crack that cannot be repaired, or the bone loss around it is past the point of saving, or the structural remaining tooth is too compromised for any restoration to last. The answer should include why every other option has been considered. A red flag answer sounds like, well, implants last longer than natural teeth anyway, so let's just do the implant. That is not true in most cases, and it is not the right reason to remove a tooth that could still serve you. If you hear that, get a second opinion from a dentist who does biomimetic restorations, and a third opinion from an endodontist before you make the decision. If you only remember one thing from this video, let it be that no natural tooth, once removed, ever comes back, and that in many cases the tooth was removed too soon. Question 2. What material is the implant, and what materials are the bone graft and the crown made of? Let me say something that's going to surprise you. There is more than one kind of implant. The most common is titanium, which has decades of clinical data behind it and works very well for most patients. There is also ceramic, sometimes called zirconia, which is metal-free and has become a serious option in the last 15 years, particularly for patients with metal sensitivities, autoimmune concerns, or aesthetic concerns at the gum line. Neither one is automatically right. Both have their place. The question is whether your dentist has actually thought about which one is right for you, or whether they are using whichever one they happen to stock. The bone graft conversation goes here too. If your jaw lacks the bone to hold the implant, a graft will be placed first. That graft can come from your own body, from another human donor, from an animal source, or from synthetic material. Patients deserve to know which source is being used, why that source was chosen, and what the alternatives are. A good, honest answer sounds like, in your case, we are recommending a ceramic implant because of these specific factors, and a synthetic graft material because of these specific factors. A red flag answer sounds like, don't worry about that. We use what we always use. You deserve to know what is going into your jaw for the rest of your life. Question 3. What is the actual condition of my bone, my gums, and my overall health? And how does that affect whether this implant will integrate? Now, and this matters, an implant is not a standalone object. It is a piece of metal or ceramic that has to fuse with living bone in a process called osseointegration. That fusion depends on factors most patients are never told about: bone density, gum biotype, vitamin D status, smoking history, diabetes control. Certain medications, and there are several common ones, including some prescribed for osteoporosis and some for autoimmune conditions, that can interfere with bone healing in ways that change the conversation entirely. Hormonal status, particularly postmenopausal, which affects bone metabolism. Chronic inflammation, including from gum disease elsewhere in the mouth. A good, honest answer sounds like, here are the specific tests we ran on your bone density and your overall health. Here's what your medications mean for healing. And here's how we're adjusting our plan because of those findings. A red flag answer sounds like, your x-ray looks fine, let's schedule. An x-ray alone, without a real conversation about your medications, your hormones, and your overall inflammation, is not enough planning for a procedure this final. Now here's the part that's going to surprise you. Implant failure rates climb with age, with osteoporosis medications, with uncontrolled gum disease, with smoking, and with poorly controlled diabetes. Research published in the major dental journals over the past 2 decades has been very consistent on this. A patient in their 70s with several of those factors has a meaningfully different success curve than a patient in their 50s without them. That doesn't mean don't get an implant. It means the conversation should be honest about what success looks like in your specific picture. Question 4. Who is actually doing this procedure? What's their experience? And what does failure look like if it happens? A dental implant placed by a general dentist who does a few a year is not the same procedure as one placed by a periodontist or oral surgeon who does several hundred a year. The success rate of the second is meaningfully higher. Ask directly how many implants the practitioner has placed, what their failure rate has been, and what they do when one fails. Ask whether they use cone beam CT imaging. That's 3-dimensional imaging of your jaw for the planning, because flat x-rays alone are not enough for a procedure this precise. Ask whether they use surgical guides made from that imaging. Ask what their post-operative protocol looks like, including how they handle infections, how they handle a graft that doesn't take, and how they handle an implant that doesn't integrate. A good, honest answer is, here's exactly how many of these I've placed. Here's my approximate success rate. Here's what we do if something goes wrong. A red flag answer is anything vague, dismissive, or evasive about experience and failure. The dentist who is honest about what can go wrong is the dentist whose hands you want to be in. And listen, I get it. These questions feel awkward to ask. I am giving you permission to ask them anyway. A real practitioner welcomes them. A practitioner who is offended by them is telling you something useful about whether you should be in their chair. Here's where the gap comes in. Implant planning protocols, biocompatibility testing for material sensitivities, advanced imaging, surgical guides, and the conservative biomimetic options that may save the tooth in the first place. Those all require trained practitioners. I won't walk you through DIY versions because there are no DIY versions of implant decisions. The value here is knowing what to ask. Let me tell you about a woman I'll call Susan. 65, retired hospital administrator, came to my office with a treatment plan from another dentist for 2 implants on her upper right side. She had been told 2 of her teeth were beyond saving. When we ran through the 4 questions together, the picture changed. Her bone density had never been measured. Her vitamin D was significantly low. She was on a common osteoporosis medication that her dentist hadn't asked about. And on closer look at her teeth, one of the 2 could be saved with a careful biomimetic restoration after a root canal retreatment by an endodontist. She did not need 2 implants. She needed 1. She did not need that one immediately. She needed 3 months to address her vitamin D, work with her physician to evaluate the medication question, and make sure her gum disease elsewhere in her mouth was under control before any surgery. 3 years later, the saved tooth is still in her mouth. The single implant integrated beautifully. Susan's case is, in my practice, more common than the alternative. Here's what 25 years in practice have taught me. The most powerful tool in the dental chair isn't the drill and it isn't the implant. It is the question you ask before either touches your tooth. An implant placed in the right patient, in the right bone, with the right materials, by the right hands is one of the most beautiful pieces of modern dentistry. An implant placed in haste, without the right questions answered, is one of the most consequential mistakes a person can make with their own jaw. You do not need permission to slow this down. You do not need permission to ask for second opinions. You do not need permission to walk out of an office that won't answer your questions. A real dentist welcomes the conversation. Let's pull this together. Before agreeing to a dental implant, ask whether you actually need one, and whether every option to save the natural tooth has been exhausted. Ask what materials will be used, including the implant itself, the bone graft, and the crown. Ask what the actual condition of your bone, your gums, your medications, and your overall health is, and how that affects the success rate in your specific case. And ask who is doing the procedure, what their experience and failure rate are, and what happens if something goes wrong. Those 4 questions, asked calmly and clearly, will tell you almost everything you need to know about whether the implant on the schedule is the right one for the right reason. You are not a passive patient. You are an active participant in your own care. The dentist holds the instruments, but you hold the choice. And the choice here is one that will live in your jaw for the rest of your life. In the comments, tell me, have you been quoted an implant, and which of the 4 questions feels most important to ask? I read them. If this helped, hit the like button, subscribe, and share it with someone over 50 who needs to hear it. Take care of your teeth. They're irreplaceable. I'll see you in the next one.